Hello everyone and welcome to set 17 of the part 1 questions. Let's get going. First question here. A 3-year-old patient presents with a fever of 102 degrees Fahrenheit for the past 3 days. On the 4th day, the patient develops a red macular rash over the entire trunk and her fever resolves abruptly. What viral infection is most likely in this case? So this is a classic sign for roseola. So roseola, you're going to have very high fevers lasting for several days, followed by a very diffuse macular rash, and then the fever just goes away. Next question. What are the mechanisms of action of the following toxins? So the first one we have here is strychnine. So this is a glycine antagonist, and it blocks glycine receptors. And glycine is an important inhibitory neurotransmitter, and that's going to be in the spinal cord. So when you give strychnine and you're blocking that inhibitory function, you're going to cause a lot of activation, so a lot of muscle spasms and even asphyxia. Tetanus toxin, also called tetaноspasmin. This is also blocking inhibitory function of glycine, but it's also blocking GABA, and that's another important inhibitory CNS neurotransmitter. So it's basically binding to specific inhibitory cells called these Renshaw cells, and these cells actually release glycine and GABA. So if you block this inhibition, you're going to get overstimulation again, and this leads to muscle spasms. Next, we have black widow spider toxin, also called iatrotoxin, and it's going to cause excessive release of acetylcholine. So the motor neurons are just going to dump all this acetylcholine into this synaptic cleft, and this leads to muscle pain and muscle cramping, as well as a host of other symptoms as well. Botulinum toxin really is just going to do the opposite of what we just talked about. So it inhibits the release of acetylcholine at the neuromuscular junction, so it causes flaccid paralysis. So we use Botox injections to treat certain disorders where you have too much muscle spasms. And then we have something called the alpha bungarotoxin, kind of a funny toxin, and this has similar results. It binds to the postsynaptic nicotinic acetylcholine receptors at the neuromuscular junction. So again, you have flaccid paralysis. This is a toxin found in the venom of a certain type of Chinese snake called the kite, which is why you've probably never heard of it. This maybe is a little bit lower yield, but still, sometimes you get a mean test question that is going to ask you stuff like that. Next question. What phase of drug metabolism do geriatric patients lose first? And which phase of drug metabolism makes a slightly polar metabolite by oxidation, reduction, and hydrolysis? So first we have what phase do the geriatric patients lose first. Well, I'm not going to get into what the phase 1 reactions are and what the phase 2 reactions are right now, but elderly patients tend to lose the ability to metabolize drugs with phase 1 reactions first. Now, which phase of drug metabolism makes a slightly polar metabolite by oxidation, reduction, or hydrolysis? So these are the phase 1 reaction, oxidation, reduction, and hydrolysis. So they're catalyzed by the cytochrome P450 enzyme. So again, elderly patients lose their P450 reactions before they lose their phase 2 conjugation reactions. Next question. What is the difference between malingering and factitious disorder? So malingering is where the patient is faking symptoms or faking complaints in order to gain something. So there's a secondary gain involved. For example, a person is trying to get out of work, or trying to get out of jury duty, or drug seeking, or just trying to get attention from their family or something, but there's a specific secondary gain. Factitious disorder is where the patient claims an illness, so they're faking something, but there's no secondary gain involved. She just enjoys being a patient, being in the sick role. Maybe he comes in just wanting to get medical attention. So the patient may not even know why they're doing this, but they're aware that they're faking it. So they know that they're faking something, and they know that it's going on. But remember, for malingering, there is a secondary goal. Next. Which cancers can cause the paraneoplastic syndrome, Lambert-Eaton syndrome? So remember that Lambert-Eaton syndrome is a syndrome where you have antibodies that bind to the voltage-gated calcium channels on the presynaptic nerve terminals at the neuromuscular junction. So normally when the axon depolarizes, these calcium channels in the nerve terminals open up and allow calcium to enter the cell, and calcium is often what's making things happen in cells, so there's a lot of inhibitory stuff going on there. So here, calcium is supposed to trigger exocytosis of the little vesicles of acetylcholine so that you can transmit that signal to the muscle. But when you have Lambert-Eaton syndrome, those antibodies prevent those calcium channels from opening, so you actually block neurotransmission, and that's why you have muscle weakness. So what cancers cause this? Well, the big one is small cell lung cancer. That should definitely be the first thing that comes to mind. Then others like Hodgkin lymphoma, malignant thymoma, those are more rarer cancers, but it can cause that as well. But think of small cell lung cancer first. Next question. A patient complains of intense thirst and profuse urination. After further testing, you suspect diabetes insipidus. What urine-specific gravity and serum osmolality findings would you see in a patient with diabetes insipidus? So in diabetes insipidus, you can't concentrate your urine. Either you're not making ADH or you're not responding to ADH. But either way, you can't concentrate your urine. So your urine will be dilute with a specific gravity, usually less than 1.006. So when you can't concentrate your urine, you're going to lose a lot of free water. Your serum osmolality will be elevated, so greater than 290. So low urine osmolality and specific gravity, high serum osmolality. Next question. What is the most common tumor of the urinary tract? What is the usual presenting complaint of a patient with this tumor? What substance exposure increases the risk of developing this tumor? So the first one here, what is the most common tumor of the urinary tract? That's going to be transitional cell carcinoma. What's the presentation? You're going to see painless hematuria. And then what substance exposures increase the risk of developing this tumor? That's going to be phenacetin, smoking is a huge one, aniline dyes, and cyclophosphamide. Next question. What is a conductive hearing loss and what are some of the causes? So a conductive hearing loss means that sound is not being conducted. The other type of hearing loss is a sensorineural hearing loss where the nerves themselves aren't working well. Here the nerves are working, but the sound isn't being transmitted to the cochlear apparatus. So it's caused by wax buildup in the ear canal, ear infection, either otitis externa or otitis media, a ruptured tympanic membrane, or by a condition called otosclerosis, which is a malformation of the ossicles of the middle ear. Next question. Which conditions are associated with oligohydramnios and which are associated with polyhydramnios? And then finally here, what is Potter syndrome? So first one we have is oligohydramnios, and this is where you have less than half a liter of amniotic fluid, and it's associated with placental insufficiency, bilateral renal agenesis, or posterior urethral valves in males. And basically this condition is where you have decreased fetal urine production. Polyhydramnios is where you have greater than 1.5 or 2 liters of amniotic fluid. It's associated with esophageal or duodenal atresia, so the fetus can't swallow the amniotic fluid, and it's associated with anencephaly as well. Now, what is Potter syndrome? Potter syndrome is where you have bilateral renal agenesis, which again is going to cause oligohydramnios. You're not producing the pee. And then there are a handful of other features which result as well, which you can remember with the mnemonic Potter. So pulmonary hypoplasia, oligohydramnios, which we've already talked about, twisted skin and twisted face, which helps you remember wrinkled skin, facial deformities, extremities, or even limb deformities as well with that renal agenesis. Next question. What pulmonary artery pressures indicate pulmonary hypertension? So normal pulmonary artery pressure is between usually about 10 and 14 millimeters of mercury. Pulmonary hypertension is greater than or equal to 25 millimeters of mercury at rest or greater than or equal to 35 millimeters of mercury during exercise. All right, guys, that brings us to the end of set number 17. I hope you learned something. I'll see you next time.